everyone. A very good morning to you all. Myself, Dr. Sumedha Gupta, and on behalf of Voice of Healthcare, I would like to welcome all the viewers who have joined us. So, today we are here to present the ninth episode of Detect to Protect, a series of awareness session in fight against the breast cancer, organized by Voice of Healthcare and supported by Zydus. In today's session, we'll explore about the vital insights on breast cancer, from recognizing the signs and symptoms to importance of early detection, prognostic testings, policy advocacy, and the latest treatment options. So let's come together to empower ourselves with the knowledge that protects women's health. Before starting the discussion, I would like to share some facts about the breast cancer prevalence in India. Breast cancer in India possesses a significant public health challenge. Accordingly, for about 14% of the global burden, the incidence is rising at 1.5 to 2% annually, with approximately 60% of cases diagnosed at the advanced stages, which severely impacts the treatment outcomes. The average age of diagnosis is around 45 years, which is younger than the global average age of 61 years. And survival rates varies widely. 70 to 80% in the urban areas in comparison to 40 to 50% in rural regions. Awareness of symptoms is really low, with only 20 to 30% of women informed about this disease and less than 10% participate in the regular screening. Cultural barriers and stigma further impede timely medical help, especially for the women with the family history of breast cancer who are at 2-3 timer higher risk. These factors highlights the urgent need for improved awareness, education, and the healthcare access to address this rising burden of breast cancer in India. And in the light of these stats and facts, to begin with the discussion, first I would like to invite our guest with insightful information on understanding about the breast cancer awareness in India. I would like to welcome Dr. Ashvin Paul, medical oncologist, Arignar Anna Memorial Cancer Hospital and Research Institute, Kanchipuram. Good morning, doctor. Welcome to the discussion.
Good morning, madam.
So
Thank
let's
you for
begin
the
with the
invitation.
You're welcome, Dr. Ashwin. So let's
Mm.
begin with the discussion point. So, Dr. Ashwin, if we talk about the risk factor and the incidence of breast cancer in India, what are the primary risk factors that contribute to increasing the incidence of breast cancer, and how do these differ from rural to urban population?
When when you split it into rural and urban, as we know that we are living in a very fast-moving world, and where the time is important to everyone. So especially when it comes to urban setting, as we know that nowadays most of the women are now employed, and they are working in high stress jobs. Especially they have very strict deadlines to meet. So most of the women tend to ignore the slightest of symptoms, so they have to play two roles. One is at the workplace, and also when they come back to the home, that is to take care of the family members. So they tend to not pay attention to the minutest of detail unless the symptoms are worsened over a period of time. So maybe they might ignore the earliest symptom, which would be a pain or any discoloration or any redness or any discharge or any lump or anything can go unnoticed till they become very symptomatic towards the end. That would be a terminal stage in most of the women that we come across. So, and when we come to the urban setting, we because we are moving towards the westernization of our society, towards more of less of exercise, less of healthy lifestyle habits like eating healthy. Most of us tend to eat from outside. Most of the home cooked meals have come down because of Swiggy and Zomato, so many other online delivery platforms, which tend to, because of our work culture where we tend to save money, tend to save time. We feel that it is a laborious task to actually make food at home, so we tend to um, go towards online delivery platforms, which tend to because most of us work in areas where we are not close to home. We tend to live in cities which are far away from home. So because to cut down our time and effort, we try to go towards methods which tend to enhance the uh, as in like cut down the time required in that aspect. So we tend to ignore those things over the period of time. So food, most important thing that I would actually place in our list is food, because as we know, food is medicine. So the food, we have to look into every aspect of food that we eat, because be it because most of the food is also adulterated, whatever food we eat from outside, because of the, now only in India, slowly the food safety things are taken into strict consideration. But otherwise, slowly, as we know that rules are becoming a bit more stricter, and people are also becoming more aware of all these food habits and everything. But over the long run, if you see urban, mostly I would say stress, lack of exercise, and most of the time the food that we eat, because ultimately that plays the environment also, like pollution, because most of the time there are no rules applicable to the pollution, that the air we breathe, then the water we drink. So many things have to be taken, because these things accumulate over a period of time. So hereditary, as we all say, genetic, so that is only out of the breast cancer incidents or cases that have been reported, only around 15 to 20% will contribute to hereditary breast cancer. But other thing is mostly sporadic. Sporadic is what we say is those which are acquired over a period of time, the mutation that develop in our body because of our whatever environment, the whatever factors which I've told you. So so in rural aspect, if you'd see, they are slightly more I mean there, because most of the people resort to farming, agriculture, so they inherently come in exposure with all the chemicals, that is the fertilizer, pesticides, insecticides. So those type of chemicals tend to play a big, because they pollute the underground water which they drink. So most of the time that is one of the but their exercise, and they are slightly more tolerant, because they eat also, because they mostly cook at home. So that the etiological factors different between the urban and the rural. So according to the Globocan data, which actually tells about the incidence and the mortality rates that contribute about each cancer which contributes to the mortality rate in India. So you would see that the all-time the cancer incidence, both male and female combined, breast cancer contributes to the main cancer incidence, combining both male and females. And in females, if you see, breast cancer contributes to the majority of the cancer burden. And the all rate cancer mortality, that mortality which happens because of cancer, the one of the main cancer that causes to the cancer mortality in women is breast cancer. So
Thank you, Dr. Ashwin, for providing us with these insights. Moving ahead with the discussion, if we talk about the signs and symptoms, so what are the most common and early signs and symptoms of breast cancer, and how can someone differentiate between the benign changes and the potential cancer symptoms?
mostly when you look at breast cancer, the one of the the main thing that brings a patient to the hospital or to a clinic is pain. So the problem with breast cancer, the lumps, is that they don't have pain at all. So mostly it'll be a painless mass which has been sitting there in the breast, which should be tend to be ignored, because one of the main thing that helps that any patient or anyone who goes to a hospital or clinic is pain. So when they don't have pain, they tend to ignore it. That is one of the main thing. Other second thing is associated skin changes which would happen around the lump site, where it would be redness or any inflammation or any kinds of discoloration which happens. So most of the time they need not be like, there could be no redness or may not be any redness. Other thing is discharge, nipple discharge, which would be slightly blood tinged, or sometimes you can have even ulceration, where the tumor becomes slightly big and then you have an ulceration over the skin. And something we call as pudi orange, just like how the skin of the orange is, we can see those type of dimpling, small dimple like formation can happen around the area where the tumor is. Then the other factor would be, sometimes you can have swelling which would be there in your axilla, that is your armpit, and also in the neck. So any swelling, which abnormal swelling, so all these things can be felt when the patient sorry, when the individual is taking their bath, or if they're lying down in the bed, or before going to sleep, they can just have a feel of their breast, the neck and everything, and see if everything is okay. At least that gives you a gross idea that okay, there is no problem. But the issue happens when people tend to ignore all these things, and by the time they come to the hospital, most of the in the western data, when you see that majority of the people present in the early stage, but in India, the issue is that most of them present in a locally advanced, that is stage 3 or more, or even stage 4. Around majority of the cases present in stage 4 and stage 3, which is in a situation where we might not consider doing surgery upfront. When those types, we might have to consider chemotherapy upfront. So I think because we need to have a lot of educational programs and a lot of awareness programs which have to be taken into consideration, and the people also get educated about all these things. So I think you're doing a good platform. This platform will help them in ensuring that these are the signs and symptoms.
Thank you, Dr. Ashwin, for providing us with the insights on sign and symptoms. If we talk about the screening guidelines, so what current guidelines for breast cancer screening in terms of age recommendation and the frequency, and how can family history influence these recommendations?
So as you know, the data doesn't. I mean, most of the studies which have been done by studies which have been done outside India, that is in the Western world. So most of the studies, they show that there is no benefit by doing a clinical breast examination or self breast examination. But that benefit, as in like it in medical oncology aspect, we look at survival. Is there any survival benefit? But they do recommend that, especially they have something called high risk criteria. High risk, who all contribute to a high risk is any individual who has a lifetime risk of having breast cancer more than 20%. So this 20% gets derived by doing, there are a lot of predictive applications like online apps or prognostic models. Like I don't want to name the model, but there are different types of prognostic models which help in determining the risk, the lifetime risk of the individual to have breast cancer. So the breast cancer, if the lifetime risk is more than 20%, then these individuals should, they get labeled as high risk. So they have to follow the screening guidelines where they will recommend to do a mammogram. If it's less than 30 years, um, mammogram cannot be done because the breast in young females should be slightly dense. So in that screening mammogram, you won't be able to make out um, visible lump or anything cannot be made out because everything will be white. So you won't be able to pick up any abnormality. So in those cases, they recommend doing an MRI breast. But if it's more than 30 years, especially on high risk, especially individuals who are BRCA1 and 2, that is the main genetic risk mutations which are associated with breast cancer. So, if any family member who's carrying this gene, that is BRCA1 and 2, then they would recommend to do an alternate 6 monthly mammogram, alternating with an MRI breast to pick up those lesions at the earliest, because these BRCA1 and 2, they tend to be a bit more aggressive breast cancer. So if you pick it up at the earliest, we can recommend these patients to go ahead with something called prophylactic mastectomy and prophylactic bilateral salpingo-oophorectomy, that is removal of the breast and ovary.
Thank you, Dr. Ashwin, for these insights. And if we talk about the self examination techniques, so what effective self examination techniques can we use to identify breast cancer early?
Self breast examination technique that has to be. I mean, you have nowadays we live in an era where we have information is easily accessible through YouTube videos or through so many other platforms. You can just see how to do a self breast examination. You can do it from one direction. That would be either clockwise or anti-clockwise to feel at every quadrant of the breast. The breast gets divided into four quadrants. You have the if you have the right breast, na, right upper and lower quadrant, right outer and inner quadrant. So the thing is, four quadrants get divided, and then based on every quadrant, you have to just keep on rotating in one direction so that you feel for any abnormality in your breast. But per se, the patient themselves, if you feel that there is any obvious mass that is felt, anything has to be taken into suspicion and has to go seen by a doctor who's nearby, or any other, as your whichever hospital you would want to go.
Dr. Ashwin, can you hear me?
Yeah, yeah, I can hear you.
Yeah. And if we talk about the impact of early detection in breast cancer, so how does early detection impact the treatment options and the recovery rate for breast cancer patients?
Okay, early detection. Why we are saying early detection is that most of the Western people, they tend to, because they have a very robust screening system, they help in picking up these lesions at the earliest. So they tend to have a better overall survival, that is close to, like, if you pick up a breast cancer which is in stage 1, stage 2, so the survival is close to like almost 80 to 80 90%. So the thing is, but the survival kind of dips down once it becomes stage 3, stage 4. That we look at a 5 year overall survival, that the patient surviving for long. So that survival where they can be like a normal person and without any other toxicity, like unnecessary chemo can be avoided if you pick up those lesions in early lesion. Now we are moving towards a phase where we call de-escalation therapy. But the main basic test that we try to do is, there are three receptors that we do. One is ER, PR, and HER2. So any breast lump has to be evaluated for those three markers. So if you have any lesion which is ER, PR, HER2, everything negative, that triple negative, it's called triple negative breast cancer. Those breast cancer are more common in the Indian younger women. And according to literature, Indian women, the breast cancer that we see in the Indian population and the breast cancer that we see in the Western population is totally different. The behavior wise also different. So we, so many centers now, we are coming up with so many guidelines from Indian, for Indian patients per se. We cannot extrapolate the Western guidelines to our Indian population, because the Indian population, the breast cancer is totally, the behavior is totally different from the Western population. So we need our own guidelines and own data to back this finding. So especially there's so many literature which is coming out from India, which is telling that the Indian breast cancer, especially the triple negative, that it presents 1 decade earlier. That is 10 years ahead compared to the Western peers. So say if you have a lady who is diagnosed with triple negative cancer like 40 to 50 years, this triple negative cancer gets presented at 30 years. So 1 decade earlier it's being presented. And this breast cancer subtype which I'm talking about, ER, PR, HER2 negative, all three markers negative, is very aggressive. So if you have a small lump, if you picked it up in 1 week, then within 3 or 4 weeks, it can be a stage 3 or stage 4. That's how rapid it progresses. So such type of rapidity in symptoms, like where you see maybe clinically you see 1 week before that the lump size is very like a pea sized, small lump, and then suddenly patient ignores it, and within 2 3 weeks it can be become like a big round, like a lemon or orange size. It That's how rapid it is. It's very aggressive. So these type of tumors, that's why the onset, that's why we are advocating for screening, early screen. So such type of lumps, if get picked up early, we would know what it is, instead of you ignoring and saying it's a fibroadenoma. Like sometimes we have something like younger females, some of people do not take it seriously because they say, oh, something like a fibroadenoma, which is a misnomer, which is a major problem which happens when people just go to some, they'll say, okay, young female, there's a lump, could be mostly fibroadenoma. But the thing is, such type of patients, when the individuals, when they come after 3 months, they would have progressed rapidly, because unless you do a biopsy to confirm that lump, whether it's benign or malignant, you cannot say from an outside perspective, that's with your naked eye, that it is malignancy or benign. So ideally, any breast lump, I would advocate that they should do a biopsy. Even if your imaging might say it is benign, probable malignant, but get a biopsy done. Do not get an FNAC done. FNAC is just
Yeah.
putting one needle and saying benign or malignant. Do not do that. Just get a biopsy, because as we see that so many Indian people, so many Indian medical oncologists are dedicating their lives in bringing out data from India. So our Indian population tends to behave differently. So I would advise, because especially in India, finances play a big role, because in Western population the insurance take care of majority of the treatment, whether it be anything. In India, the family bears the brunt of one person's illness, and most of us are not insured. So as we come to the old saying, prevention is better than cure. So
Yeah.
prevent it before it happens.
Thank you, Dr. Ashwin, for providing us with these insights. Since you mentioned about the biopsy, so there are so many myths in Indian population that if they get their biopsies done, that the cancer cell will spread to other parts of their body. So, what's your point of view onto that? I mean, how we can bust this myth?
No, that look, the thing is, biopsy will not. Any biopsy should be done by a qualified person, whoever is treating you. The problem, majority of the problem, what happens in India is there is a lot of doctor shopping. Like, you have to place your trust on one person. You cannot build. You cannot succeed in anything without having trust in anyone. If you trust someone, only you can move forward. If you keep moving from one person to the other, from one person to the other, you cannot. Because everyone will have, you have to place your full faith in one person, whoever the treating doctor is. So most of the doctors are not there to do any harm to anyone. They are doing it everything in consensus with the guidelines only. No one is going to unnecessarily cause any harm to anyone. So without doing biopsy, you cannot confirm whether it's cancer or benign. So it's better to be on the safer side than to regret later and then saying, please do something to help me. Beyond the, but that time the train would have already crossed the station. So that is too late. Because one thing you have to understand, that at least in the Western population, they have lot of clinical trials. So many clinical trials keep happening for new molecules. For them, treatment gets covered in some way or the other. So most of the patients who volunteer for clinical trials, which can be done in a stage 4, and sometimes the drug turns to be a wonder drug. For example, transdermal durostican. It's done in a so many patients have accessibility to those type of trials. But in India, we don't have those type of trials. We don't have like a clinical trial gets done for our patients. So that aspect has been, and any drug that gets released in US or UK or any European country, by the time it percolates to our Indian population, there is a time lag of already 5 to 10 years. So
Okay.
we have to work around our own logistics. So we at the same time, we cannot be like a Western population. We have our own problems with our own systems, and we have to work around. Because if you break down, the problem is with most of us don't have insurance systems in place. We don't have insurance now. Only slowly, people post COVID, people are slowly getting educated because of the social media, and so many influencers kind of educating people. Slowly people are putting a lot of insurances to ensure that they have adequate financial insurances to cover these uh, unforeseeable events. But the thing is, without biopsy, we cannot say. The invasive component gets picked up only on by doing a biopsy. And if you
Thank you,
have to
Dr.
do
Ashwin.
and if you have to
Yes.
do those ERP or HER2 in case it's malignant, then we can only confirm on biopsy. But it has to be done by someone who's trained, and who is that nowadays anyway, people before meeting a doctor, they anyway do their check. they do their checklist before going to a doctor. So I don't think uh, it applies that anyone is not advocating without doing a biopsy. That is totally a unreasonable claim that with doing biopsy it's spreading.
Thank you, Dr. Ashwin, for bursting out this myth very wonderfully and positively. Moving ahead with the discussion, if we talk about the treatment methods, so what are the latest advancements in breast cancer treatment, including the immunotherapy and the targeted therapies?
So the thing is that we are moving towards era of personalized medicine. Personalized medicine is where every individual is different. We do have a chemotherapy background, that is a blanket chemotherapy protocol that we follow for all the patients. But as and as because of the advancements in science and better diagnostic methods and better molecular methods, now we are moving towards an era where we are individualizing treatment to every patient as separately as possible. So, based on their tumor profile, tumor characteristics, we are trying to individualize treatment to them. So, this is an era of personalized medicine. So, the thing is, latest therapies have been approved, especially immunotherapy, where we have pembrolizumab, and based on trials like Keynote 522, where in triple negative breast cancer, which I've already talked about, the most aggressive. So we are trying to incorporate neoadjuvant. Neoadjuvant is giving any chemotherapy or immunotherapy, any systemic therapy before doing any local therapy, that is your surgery or radiation. Before doing any of this therapy, we are incorporating any systemic therapy, that is neoadjuvant. So in this case, especially in triple negative breast cancer, these tumors are very. We do something called a PDL1 testing, where we look for immune cells. If you have lot of immune cells in that biopsy sample, that is one of the reason why we have to do a biopsy. So to know exactly to do these tumor NGS, that is the next generation sequencing. Molecular testing has to be done to study the tumor behavior. Based on that tumor behavior, we'll know whether to give immunotherapy or not to give immunotherapy. Especially, there are benefits of giving neoadjuvant immunotherapy, especially in the tumor subsets, to triple negative breast cancer subsets. They tend to do much better, and the response rates are much better, and the survival also is better. The disease-free survival. So we are moving into an era where immunotherapy is coming to this subset of breast cancer. And the
Yeah.
other thing is targeted therapy, where we tend to look at the other pathways like PIK3 in PIK3 CA pathways, where we have a lot of these molecules like all the PIK3 inhibitors, and then we have a lot of HER2 therapies, directed therapy, where we have a lot of. Now the recent molecule that gets approved is transformer durostican, which has got a magnific yeah, based on the Destiny Best trials. So many trials were done, and it's now recently also you would have read that the government of India has brought down the excise duty on this drug because it's brought a magnificent benefit, especially 23 months PFS, close to benefit for a stage 4 breast cancer, which is phenomenal data for that. And especially, uh, also we are now, maybe in the future we have something like CAR T cell therapies being developed for like especially in blood cancers, where specifically targeting one cell, taking the person's immune cells outside, and they are modulating and then sending it back into the body. Maybe in the future we might have something like CAR T cell therapies being developed for breast cancer, maybe with regard to HER2, because HER2 is uh, before the advent of trastuzumab and pertuzumab, all the HER2 blockade, before Dr. Dennis Alvin, who in the early 90s came out with the wonder drug called trastuzumab. Before that, HER2 was a as soon as the patient gets diagnosed with HER2 breast cancer, the survival will be just in months. But because of the advent of these new molecules, the survival has been prolonged. So maybe in the future we might have something like CAR T cell therapy for HER2. We don't know, but we are moving towards an era. We are going away from chemotherapy, which is tend to be very toxic. So moving towards new biologicals, and we are trying to understand the immune system of every person when they fights the tumor in their body. So we are moving to an era where we less side effects, less toxicity, better quality of life.
Well, that's really enlightening to know about these latest treatment options. And in conclusion, our objective for today's discussion was to explore and emphasize the importance of breast cancer care by integrating insights on recognizing the signs, symptoms, screening methods, and the latest treatment options. And I'm confident that our experts have addressed this crucial topic comprehensively and effectively. I would like to extend my gratitude to Dr. Ashwin for your insightful contribution and for sharing your expertise with us. Your participation has been really valuable, and we deeply appreciate the time and knowledge that you have shared. Thank you so much.
Yeah, thank you.